Welcome to The Explainer. Today, we are diving into one of the most common and, frankly, one of the trickiest presentations you'll ever face as a clinician, the patient with abdominal pain. Let's break down the approach.
Okay, let's just jump right in. Abdominal pain is a huge reason people end up in the emergency department. For anyone in training, figuring out a solid, reliable approach to this, well, it's an absolute must. It's a skill you've just got to nail down. So first, let's kind of set the stage. The real challenge with abdominal pain, it's all about your clinical judgment. You're on the clock, and you have to figure out, is this something benign, or is this a life-threatening emergency that needs the OR, like, right now? So, how do you even start to solve this puzzle? Well, first you have to learn to speak the body's language. The pain itself, its character, its quality gives you your first massive set of clues.
Okay, this is so important. We're looking at the evolution of pain. It often starts as visceral pain. That's that deep, dull, kind of crampy feeling you get when an organ is stretched or spasming. It's hard to point to exactly where it hurts. Think about early appendicitis, right? The pain's just vaguely around the belly button. But then, if that inflammation spreads and touches the lining of the abdomen, the peritoneum, everything changes. The pain transforms into parietal pain. It becomes sharp, it's intense, and the patient can point to it with one finger. That's the point where they don't want to move, at all. That transition, that's a huge diagnostic clue. And then you have the third type, referred pain. Oh man, this one is the ultimate clinical curveball. You've got pain showing up in a place that's nowhere near the actual problem. And if you don't understand why this happens, you could end up chasing a diagnosis in a completely wrong part of the body. This diagram is perfect because it shows you exactly why that curveball happens. It's something called the convergence projection hypothesis. Basically, you've got nerve fibers from an internal organ and nerve fibers from the skin, and they all travel back and meet up at the same point in the spinal cord. Because your brain is way more used to getting signals from your skin, it gets its wires crossed. It thinks the pain is coming from the skin, not the organ. And this is where it all clicks into place clinically. This neural mix-up is the reason for some classic medical signs. That textbook example of right shoulder pain from a gallbladder problem, it's because the nerves from the diaphragm and the nerves from the shoulder share a root. It's not a coincidence. It's pure neuroanatomy. All right, so now that we get the types of pain, let's build on that with one of the most practical tools in your entire diagnostic kit, geography. Simply put, where it hurts really matters for narrowing down what could be wrong. I want you to think of this table as your mental map of the abdomen. A patient points to the right upper quadrant. Boom, your brain should immediately be thinking gallbladder, liver, cholecystitis. They point to the left lower quadrant, you should be thinking colon, maybe diverticulitis. And check this out, look right in the middle. Periumbilical, there's early appendicitis. That's the visceral pain we talked about before it moves to the right lower quadrant and becomes that sharp parietal pain. See, that geographical shift tells a story. But here's the thing. Location isn't the whole story. To really level up your thinking, you also need to think mechanistically. I mean, what's the actual process going on that's causing the pain? This is another, sometimes even more powerful way to organize your differential diagnosis.
Okay, so a huge bucket of causes is inflammation or infection. This can happen a few ways, right? You could have a perforation, a hole in the appendix or an ulcer, spilling stuff into the abdomen. You could have a primary bacterial infection, or you could have intense chemical irritation, like the digestive enzymes in pancreatitis. All of these tend to cause that really severe, constant pain.
Next up, let's think about obstruction. So you get a blockage in a tube, like your intestine or your ureter. What happens? The muscle in that organ squeezes down hard, trying to push past the blockage. And that is what creates that classic, crampy, on and off visceral pain that people say comes in waves. Now this next category, vascular problems. These are the ones that should make the hair on your arms stand up. We're talking about true emergencies you just cannot miss. Things like a ruptured aneurysm or a blood clot cutting off circulation to the bowel. The classic story here is sudden, terrible pain that just seems way out of proportion to what you're finding on your exam. And please always remember to think outside the box, or in this case, outside the abdomen. A heart attack can absolutely present as stomach pain. Pneumonia can irritate the diaphragm and feel like belly pain. Even a metabolic crisis like DKA can cause a ragingly painful abdomen. You can't afford to get tunnel vision. Okay. So we have all these concepts, pain types, locations, mechanisms. That's all great.
But how do you actually put it all together when you're standing at the bedside with a patient, maybe at 3 in the morning, and you're trying to figure this out? It all comes back to the absolute fundamentals of medicine. First, and most importantly, you have to take a meticulous history. Just let the patient tell their story. Then you do a thorough, careful physical exam. But it doesn't stop there. The third point is critical. You have to reevaluate constantly. The story of an acute abdomen unfolds over time, and you need to be there to see how it evolves.
And this is the real take-home message. Look, no CT scan, no lab test will ever replace your brain and your hands. A good history and physical don't just magically give you the diagnosis. What they do is they allow you to build a smart differential, and that tells you which tests to order and how to make sense of them. It is the absolute foundation of everything.
So always remember, thinking systematically about the type of pain, the location, the mechanism, and grounding all of it in a solid history and physical, that is your most powerful diagnostic tool. The answer is almost always hiding in the patient's story. So the real question is, are you listening carefully enough to find it? Thanks for watching this explainer.